Good morning and welcome to the 5th meeting of the Health, Social Care and Sport Committee in 2026. I've received no apologies for today's meeting. The first item on our agenda is for the committee to decide whether to take items 6 and 7 in private. Do members agree to take these items in private? The second item on our agenda is to take oral evidence from the Patient Safety Commissioner for Scotland. The committee has lead responsibility for scrutinising the primary legislation that created the role of the Patient Safety Commissioner earlier this session. This morning is an opportunity for members to ask Scotland's first Patient Safety Commissioner about her experience of the role and initial priorities since her appointment began in September last year. And I welcome to the committee Karen Titchener, Patient Safety Commissioner for Scotland. And we'll move straight to questions, and Emma Harper.
Thanks, Convener. Good morning to you, Karen. During the whole process of establishing a Patient Safety Commissioner, it was stressed that public confidence in Scotland's healthcare system is a core reason for establishing an independent Patient Safety Commissioner. So I'll be interested to hear about how you can demonstrate independence from government in order to pursue your Patient Safety Commissioner role.
Thank you for that question, and thank you for allowing me to be here today. At every meeting and at every point, the first thing I say is that I'm independent of the NHS, of government. So I do try and emphasise that to anybody that I meet. For me, in every meeting that I have had, in order for this role to be successful, I have got to collaborate with people because I can't do it in silo. So it's for me, it's measuring the collaboration while remaining fiercely independent. So that is what, if I'm meeting with government, if I'm meeting with an NHS board, I still have that that independent voice. Even at the latest maternity and neonatal task group, I'm probably about the only independent on the Royal College for Nursing is on there, but most of it is, board members, Healthcare Improvement Scotland. So I did say at that, just so that I am always going to bring it back to the fact that I'm independent and that we need to have independent voices at all of these meetings. So it's fiercely in my DNA for this role. So I hope that I'm able to do that.
Okay. Do you think that the current statutory provisions gives you enough independence? Do you think there's any limitations?
I have that in my head that there may be, but until I'm still in the process. Obviously, I've been in position 5 months. I haven't got my team in yet, so I haven't sort of opened the floodgates for major investigations and inquiries. I'm hoping that I have enough in the Patient Safety Commissioner Act that I can, if I find something very serious, that I can act. But again, I've been discussing escalations for that. So if I find something a little bit like Healthcare Improvement Scotland can escalate to government, I'm hoping that with what I can do, I have that same, tiered approach to when I'm concerned about something.
Okay, thanks. And then we know that the Patient Safety Commissioner in England, I think, had their 2-year report. I think we're almost at the anniversary for that 2-year report. But there's also thinking about people who feel they were never listened to, which established the Patient Safety Commissioner in England, like mesh survivors. And then there's also, we took evidence about sodium valproate and how that has affected people as well, and then prima dose was the other thing. How I'm thinking about how do you support the ability to give people confidence who've had been failed previously, who felt they hadn't been listened to? How do we take that forward?
Yes, I mean the Act specifically says that I shouldn't be looking at past, but I have been very involved with Sodium Valproate Scotland and the MESH group. And in fact, I was down in the House of Commons last Thursday. I was invited to a patient safety forum, and there was the MESH advocate down there and Henrietta Hughes, who's the English patient safety commissioner. And Henrietta has given Westminster, the Hughes report, trying to get Westminster to move forward with the redress, because in Scotland the main concern for the patients is twofold. One, the redress, but also that people understand the syndrome that is attached to the medication, for example. So when they go to social care and try and get help, people think, well, what is sodium valproate syndrome? So I've been speaking to the Health Minister and asking, is there anything we can do while we're marking time for Westminster decision? Because patients' lives are being affected now and today, still with that ongoing. So, I didn't really get anywhere with that, but I'm still trying to, again, I'm trying to say, well, can we push Westminster? Because we have got a large patient group that have been affected by that. So I heard only yesterday that Henrietta is meeting again with Westminster to try and say, this has been dragging on long enough, how are we doing it? So I'm very involved with it, through England and Scotland, so that, because some of it is not a devolved government decision. So I'm trying to think, how can we drive that forward so that the patients still feel heard and still feel listened to, and that we actually do something about it.
Okay, fine. It's just a final question then. Is there movement on redress, or is it just not going anywhere? Is there a reluctance to address the redress for sodium valproate?
There is, because of the amount of money that it's going to cost. Because I meet with MHRA regularly. I meet with them every month, and I've been asking them, and and one of the things that they said is it's because of the huge cost of the redress. So they still haven't made a decision if they're even going to redress, let alone how much they're going to do it. So there's still that. So that's why, I was trying to say we've got to do something about this, because, the Cumberledge report, was 5 years ago, I think. So it's just like, well, where are we with that? So I think we still have to keep pressing Westminster. So I'm still talking to Henrietta, about what can I do to help you move this forward.
Okay, thank you. Thanks, Convener.
David Torrance.
Thank you, Convener. Good morning, Commissioner. What mechanisms and process will you establish to ensure that meaningful participation of individuals with lived experience is shaping the work of your office?
Two things, well, many things, but the advisory board, the advisory group that I'm establishing, and we're meeting in March for the first time. I haven't quite narrowed it down for a date yet, because I'm waiting for my team to come. But there has to be 50% patient representation, 50% clinical representation in that. So I've got the voice of the patients on that. I can probably get more voices in there, as it grows, because at the minute I've only got 6 people on there, but I have to balance it, that 50-50. But also, whatever I do, so like the maternity and neonatal task force, the reason why I'm there is absolutely for the lived experience for all the families, not just the mums that have serious concerns about maternity care in Scotland. So wherever I go and whatever I'm invited to, the lived experience is the biggest thing that I bring to those things. So, I've been out to Stranraer to meet with the people there who have been affected by, maternity services that have been reduced. I'm talking to the people in Wick and up that way, and they want me to go up and meet with them. So I've been out to patients' homes. MSPs have asked me, this patient, even though their operation was 2007, I still feel that the voice of the patient needs to be heard. And if they haven't felt heard, and it's almost 20 years later, we're doing something wrong. So often, I do say to people, I don't come with a magic wand or a pot of money, but I do come with a listening ear and what is it that you want, that you're asking for to find your peace, if you like, 20 years on, if you're still anxious and concerned about what happened, we have to look at, how we address that. And even with the Stranraer families, some of them have got PTSD from the things that happened. And so I'm trying to say to Dumfries and Galloway, what are you doing about, serving these patients who actually they feel that your care damaged them, emotionally? You should be supporting them through that. So, I'm pushing back and challenging the status quo because that's what my role is to do.
Just slightly to expand on that, marginalised voices, how will you ensure that disabled patients or ethnic minority groups or rural communities are captured meaningfully in what you're doing?
Well, I have met with many disabled people on Teams, and one of them, I've said when I can balance my the advisory group that they will come onto that because his care that he got ended up making him disabled. So I think, but he's not a he is someone who will bring a meaningful discussion to the table. So ethnic minorities, I haven't got my website set up yet, but actually what I want to do is, I'm in the process, but everything takes a long time. But when I have that set up, I want to have open access that people can have a discussion with my office, and I'm also very, very willing to travel out to, because like the people in Wick that were talking to me about the maternity care, they said, well, we can't travel to you. And I said, well, that's fine. I will come to you and I will meet with you. So I want to meet the patients where they're at, but I also can't repeat, part of the Act is that you don't interfere or repeat processes. So, if it's an individual complaint, they have to go to the Ombudsman and, other things before that. But so I try and not interfere with due process, but at the end of the day, I still want to support patients who are going through something that they're still not feeling supported. So I don't turn people away, but I do signpost them. But the whole point about this is that it's all about hearing the patients. And even now, stories that I'm hearing, the patient's voice is still being ignored. So we have to do something better in Scotland in order to amplify that voice and actually change practice because of it, change healthcare because of it. So, that's the big picture. The small picture is how do you do that on a daily basis? How do you manage to... So for me, in whatever I do and the conversations that I have, I always bring a patient story to that in order to try and say, well, you think there's nothing to see here, but actually the lived experience says something different.
No further questions, Convener.
Thank you. Sandesh Gulhane.
Thank you. A declaration of interest as a practicing NHS GP. Good morning. I want to turn to the Queen Elizabeth University Hospital scandal. Several families were lied to by NHS Greater Glasgow and Clyde over many years. And Scottish governments ignored their concern. And on top of that, whistleblowers were sidelined. They were called troublemakers. They were basically in trouble of losing their jobs. So what are you doing to ensure that voices of patients like them and the whistleblowers are actually listened to by Health Board and by government going forwards?
Yes, thank you for that question, and that still goes on. Only yesterday I had a conversation with somebody who is afraid for their job, a nurse who is afraid of her job, so she won't whistleblow, but she's talking to me. So it's hard to not expose people who are living in that fear while trying to implement change. But I absolutely agree with you. It's ongoing. That families are lied to and that staff are shut down rather than whistleblowing. So when it comes to my way and I hear about that, then it's very important. at the minute, I'm getting lots of candid reports, so I'm trying to, because if I don't have a name and I'm not hearing it directly, then it's very, very hard to go with that. So that was why yesterday when I heard about it, I said I'd have to talk to the person rather than it being like, you know, third-hand experience. So I think, I think, you know, as this role grows, remember it's in its infancy, and so we haven't even got our website up and going. But absolutely anything like that inquiry, you know, we have to make sure that we don't have many inquiries, but actually that the patient is listened to day one when they're concerned, or that staff is listened to day one. And if the processes that we have in place aren't working, then my door is where that's going to fall. And rest assured, I'm no wallflower. And if I hear something from a patient that is endangering life, I will be going straight to the top. I'll be going straight to the Health Minister. And I've already promised him that if I hear something, that he's going to be the first person to hear it. Because, you know, if we're going to work collaboratively, we have to, we can't have a shotgun approach. It has to be done that government know about it. But at the same time, if I tell that to the Health Minister and nothing gets done, then, you know, I will still make sure that voice is heard, whether that means going to the press, whether it means going to the health boards, because we have to make sure that we're not bolting the door when the horse is already gone. For me, what I want to do for Scottish Health is actually the proactive, preemptive, rather than, you know, the drama when something has happened. It's let's look for the little signs that are actually telling a story. I've already spoken to the Ombudsman, you know, and said, look, if you're seeing themes in a hospital like, hang on a minute, this is the third time this has happened, you must speak up to me and say, Karen, I'm a bit worried about this because this is now the third patient that's reporting that. Because the problem is we have no national reporting of, you know, that brings all the facts together. So therefore, we're kind of working in a, you know, in a very siloed area where there's little reports, you know, Daytex is here, adverse events here, you know, the Ombudsman, Healthcare Improvement Scotland. So I feel we need to try and bring all the evidence together and really, at the early stages when we detect something's going wrong, let's do something about it there and then, and not wait for the 10th patient to tell their story.
I'm so glad to hear you speaking like this, because let's be frank and honest here. This culture of secrecy within health boards, the culture of shutting down staff and gaslighting families, this isn't new to the Queen Elizabeth scandal. This has been going on and on and on. I've been in the NHS for almost 2 decades, and it's been there the entire time that I've been there. And it's because our management are working with complete impunity. Nothing affects them at the end of the day. When scandals break, something happens, they move on to the next, and nothing is happening to management. So what can you do to actually hold management to account?
I agree, and that I think accountability is the biggest feeling, because people hide behind the institution. So I absolutely accountability is one of my first things that I would be looking to, and that's not about blame, but actually you can't change if there's no accountability. If people aren't speaking up and saying, yeah, do you know what, we got that wrong? Because actually, most of the patients, that's what they want to hear. They just want somebody to say, do you know what, Karen, that care was terrible. I'm really sorry. But you know what we're going to do the next time? We're going to do you know, something else. I have that lived experience with my mum, who died a horrible death in the hospital that I trained in as a nurse. And when I made a complaint, you know, all I wanted was that nobody would die like she died, because I said, you wouldn't allow a dog to die like that, but you allowed my mum. All I wanted them to do was to say, Karen, do you know what? We're going to bring in training for our staff for end-of-life care. And actually, that is something that hospitals are bad at in Scotland. We know that. So again, you know, obviously Pandora's box is very big, and there are lots of areas where I know care could be better. But for me, holding people's feet to the fire and saying, I will not let it go until accountability has been recognised, voiced, and change has happened. Because if we're brushing things under the carpet, nothing's going to change, and care isn't going to be better. You know, Scotland does do a lot of things well, so let's make sure patient safety is actually at a global level recognised. So that is what I want Scotland to be, the safest place in the world to have surgery, to go to their the A&Es. So we've got to do that together. My office is very small, but it will be very influential, and it will be a mighty army in the army of the healthcare in Scotland.
I'm glad to hear that. I mean, the big concern for me, and you know, as a former nurse yourself, nurses are really vulnerable when it comes to whistleblowing. I think doctors have a bit more protection, especially at the more senior levels, but it's still very difficult. I think nurses are very vulnerable. I do want to ask my final question, though. So you've called for health boards to consistently record or categorise all incidents of sexual assault and rape after concerns were raised by the Women's Rights Network. That was not being done. The Health Secretary says this is happening. So my question to you is it actually happening?
Again, I had that conversation with the Health Minister at our last meeting and was reassured, like you, that was happening. I'm speaking with the Women's Right organisation to see, you know, what they're hearing about that. But for me, there were many points that were raised at the meeting that I went to for that, including, you know, chaperone policies and things like that, because, you know, this is basic human rights and human needs. And even last week, I was hearing again of staff who wouldn't whistleblow because of their concern for losing their job. But, you know, around, male patients identifying as female patients being on, you know, acute wards and acute mental health females having to lock themselves in their room because they were concerned about this. So we haven't even got that right. Now, it's everybody's right to care and everybody's right. I'm not getting into the gender realignment discussion, but I do think I'm hearing too many times about our concerns for patients, and you know, my remit is about safety. And if patients aren't feeling safe and they're locking themselves in the room because then who's looking after their mental health? You know, again, hearing stories of nurses having to share changing rooms, not just the one that's out in the press. So I think we have got to make a decision about what we're going to do with this, whether it's healthcare, prisons, you know, what we're going to do about listening to that voice and keeping patients safe. Because everybody has a right to care and everybody has a right. This isn't about, you know, a male who wants to identify as a female, because that is their right. But we have also a right to give them the care that they need, but to protect the others. And so, you know, why aren't we doing single-sex wards? Why, you know, particularly in mental health, I'm very concerned. Again, you know, when we're talking about a vulnerable group, they're a very vulnerable group. You know, older people in care are a very vulnerable group. So you know, I really want to make sure that is happening, and you know, we'll look to make sure, you know, over the next month or so, you know, what has actually taken place after that report was given.
Thank you very much.
Emma Harper.
Thanks. Thanks, Convener. Just to come back to Stranraer, I just need to remind everybody that I'm still a nurse. I trained in NHS Dumfries and Galloway and worked in NHS Dumfries and Galloway, and Stranraer is the town I was born in. So I do have a particular interest in the maternity services, and I've been working with the Galloway Community Hospital Action Group, as have other colleagues at this table as well. So I'm interested in, and we've been campaigning with them and trying to help look at options for a long time now, since 2017, since babies were stopped being born at the Galloway Community Hospital. So I'm interested to hear what your current position is. Is there a way forward? Some action has been done in terms of overnight stays when early labour is presented, instead of sending women back to Newton Stewart or Glen Luce, for instance. So I'm interested to hear what the current update is.
Yeah. I have been. I was going to have a meeting with Dumfries and Galloway and the Action Group. We didn't get the information that we asked for, so I had to cancel that meeting. And I've met with Dumfries and Galloway, the Director of Nursing and the Director of Midwifery and their Medical Director last Friday. And they are now going to be getting me the information that they didn't give me for that meeting. So, but I think what we have to look at, I understand, having to centralise things for getting the expertise, but at the same time, what I was trying to say to them is, you're not demonstrating what your risk mitigation was. So you close down the services, but you're not reassuring me what have you done to make sure that somebody who's in labour in Stranraer is safe. What have you done about response times for the ambulance? What have you done about local responders? Does somebody have Entonox? I heard about a lady having to travel from Wick to Inverness, and the ambulance didn't have gas and air, and I'm just thinking, what ambulance doesn't have gas and air? I don't understand. So I think we need to be looking at rural communities, and I actually think that we shouldn't be doing it as a whole, because I think every rural community is very distinct. I think Stranraer is distinct from the north. So I want to see what Dumfries and Galloway can do. And they are trying to reassure me, and they do say patient safety is paramount in what they're trying to do. But again, I said to them, well, you're failing to impart your risk mitigation to the locals, because they're still feeling that they're not served well and that they're still very vulnerable and at risk when they're giving birth. So we're in discussions around that. I'm going to go and meet the head midwife. She's going to take me round Dumfries Hospital. I'm going to go and meet the midwives in Stranraer as well, because you have to get both sides of the story and how they feel. But that has to be, a little bit like what was on in the BBC for the Edinburgh Hospital. These midwives have to feel free and able to tell me what their concerns are. But I do think it's been going on too long. I agree, which is why I was trying to force the issue and say, you need to tell me what mitigating actions you're taking, after you've retracted a service that was serving the local community.
Like mitigation measures of making sure
what are you doing?
Accident and emergency teams have got some Scotty training for
exactly
pregnancy emergencies, something like that.
Exactly. Which is what happens in the north. They're allowed to go to the emergency room. Not ideal to have a baby, but
no.
At least it's a safe environment. Whereas the community in Stranraer are told that they can't go to the A&E. They have to go. Which to me is just, and the other thing is, that's why I'm actually going to be speaking to the Scottish Ambulance Service, because I feel like, well, hang on, if I have a heart attack, you're going to medevac me to the A&E, but actually, if I'm in labour with twins, like happened in the north, you're going to put me in an ambulance. I'll have a baby in one place and then move on and have a baby in another. So why aren't we thinking about maternity when we're looking at, in Australia, that has rural, more rural communities than we have. We have to look at other places and think, what do they do? And therefore, what are we doing? So for me, this is about is more about how are we going to do this. And so some of the mitigation is we've got to think differently. This isn't just about brushing it under the carpet and saying, well, we feel that everything's in place and these patients are safe. I don't feel they are, so that's why I'm pushing and saying, what are you doing to mitigate the risk? And that is, for me, about more local intervention things happening for those people. But I agree with you, why they were sending somebody back home when they were in labour. Now, again, I asked for the figures of who they were offering to stay in the accommodation, and they were saying, oh, well, we don't do that because we can put them in somewhere. And it's just like, well, that's not what I heard, because I heard that you had no room at the inn and you sent people all the way back home, even though they were 5 centimetres dilated. So I think the lived experience and the perception of what the lived experience is, there's a gap.
Okay, thanks. Thank you. Thanks, Convener.
Carol Mochan.
Thank you. It's very helpful, just the last discussion you were having there with Emma. Spoken to people in that area, and even right through pregnancy, there's some of that back and forward. So, as you say, it's just trying to help people understand each other's side and actually come to a conclusion. So it's really helpful to hear you're going to be doing that work, and it leads on to some of the questions that I was going to ask you. And you've mentioned such a Pandora's box, just such a big remit. So I'm interested to know just how you're going to try and select your sort of strategic priorities. Have you had a bit of a think about that? And I know that the report highlighted that it would be important to have a sort of strategic plan. So is that starting to get put into place?
Yeah, I mean, so I'm waiting for my team to come on board so that it's not my strategic plan, and also around the principles of the office and the charter of the office, because those have to be agreed by the advisory board and then by I'm getting all these, the corporate body of the Scottish Parliament. Looking at a strategic plan, for me, there's what's the most, what's the thing that I need to focus on now, and then what is a 4-year, this is an 8-year tenure. So clearly Scotland realised that, magic wasn't going to happen overnight. It was going to take time. So I really want to think, what can we impact within the first year, and then what can we impact moving forward? What's the long-term plan? So there are some things. Obviously, maternity is a big focus, and I'm now on the task force for that. I would say the women's rights and the how safe are our hospitals. I really want to make sure that we've dotted all the I's and crossed all the T's with that, because since that report, patients should be feeling safer, but they're not, because things haven't been implemented. So I want to follow that through. There is having come from England, where we have the CQC, you've got HIS that is not a regulatory but is an inspector, but then there's also this improvement, which, not critical but does blur the edges, because how can you be good cop, bad cop? Mm-hmm. So, and I think some of the improvement that they do, they don't come with a pot of money, so therefore that's restrictive. So actually, if you actually see bad practice and you're telling boards they need to change, and yet you don't have any authority to help them make that change. I think that's quite difficult. So I think even the regulatory field in Scotland is something that, one, I'm trying to get my head around, because again, it's about accountability, and it's about making sure that we're doing the right thing for the patient. Is that my first goal? No, but I'm just aware that I'm a little bit wary of the powers that other organisations have, and is that enough to make sure that we're moving at speed, because I worry about inquiries and task groups, because for me, maternity needs sorted now. It doesn't need sorted in 5 years. So if it goes to inquiry, I think that would be a bad thing for maternity and for patients, because I think that needs a service redesign. It needs people in a room with a whiteboard saying what we're doing isn't working for patients. How do we need to move it forward? And that's what, having had many years of big operation experience, I know that's not my job, so I have to pull back and say I can't sort everything. But I do think that let's not look at inquiries. Let's look at service redesign and service change.
Excuse me, sorry. So, do you see yourself as part of your plan to really say to people, people are telling us things now, and we need action now on those issues. That's very helpful.
That's what I'm trying to do at Stranraer. That's why I'm saying, look, guys, what you're doing, the patients aren't hearing what you're telling them that's going on. It's not working. The parents still feel vulnerable. The pregnant mums still feel vulnerable. So we've got to do something about this now. Let's not leave it another 5 years.
Yeah, no, it's helpful. My last question was going to be, will you have, will your plan be dynamic enough to sort of do things as things emerge? But it definitely sounds as if that will be part of your plan, is to do what you're doing. But if things come that can be dealt with quickly, that you would aim to do that as well.
Yes.
Yeah, lovely. Thank you very much.
Joe Fitzpatrick.
Thanks very much. I wasn't really going to come in here, but a couple of times you've said something which I think would concern some of the most vulnerable patients in Scotland, so trans patients. So a couple of times you've almost implied that women need protected from trans patients, and I think just to give you the opportunity to make it clear that as well as protecting women's rights, as patients you be protecting trans
Exactly, and that's what I was saying. Everybody has a right to care, but and the perception of danger doesn't mean that it is an actual danger. So I think we have to, but what we're not doing is protecting both, because if female patients are feeling vulnerable, because they have male nurses in there, so a trans shouldn't be any different from a safety point of view. But if you've got two vulnerable people and both needing exactly the same care, it's really, really important that both of them perceive that they're getting the right care for them. And so that's why I think we've got to look at it, because I don't think we're being very clear.
So you have said that you're speaking to the Women's Rights Network, who take a particular view in terms of excluding trans people. Are you also speaking to some of the LGBTQ organisations to make sure you're hearing the real lived experience from that very vulnerable group of people, particularly in the trans section?
Yes, I haven't spoken with them as yet.
Okay, maybe. Thank you.
But you will be.
Yes.
Gillian Mackay.
Thanks, Convener. As we know, the Patient Safety Commissioner role has no remit to deal with individual complaints from patients. How do you plan to communicate this clearly to the public and manage patient expectation about your role and the level of support that you can provide?
Thank you for that. And that has happened already. Once my website is up and running, hopefully in a couple of months' time, maybe a month, that will be, I will put what we do and what we don't do, like on the front page, so that it's very clear. I do that in my presentations to anybody as well, like to boards and things like that. So, but if patients do come to me, and I do say to them, I don't do individual complaints, and give them the ombudsman, but then say, I'm still here. I don't want people to feel that I'm passing them off, and then again their voice isn't heard. So with everybody, I do say to them, please come back to me if you're not satisfied with, with how you've got on with that. So although it isn't, because some of the individual patient complaints are actually a systemic problem, so it's getting that balance. It's so between it being an individual, just bad care or unsafe care, compared to actually that's a system problem. It's not an individual patient. So I always listen to the story and think, is this a one-off, or does this need a review? And therefore, but you know, we can't blur the edges between what the Ombudsman does, which is the individual complaints, and what my office should be doing.
That's great. To overcome perceptions of a cluttered landscape of scrutiny, do you plan to develop any protocols or memoranda of understanding with other scrutiny bodies?
Yes. In fact, I just got some through yesterday. So that's what I'm trying. So that one, so that we can share information, but two, that so that our defined roles are very defined, and we don't, you know, tread on each other's toes. Because even between you know, the NMC, the GMC, all of those, you know, some patients write to me thinking I can get a doctor struck off a register and things like that. So it's very important that patients understand, but actually that I also understand, but that's not my role. So I've definitely starting to develop MOUs with other bodies to make sure that we can work collaboratively, because that's really, really important. But that we don't overstep our reach with what each other is doing.
That's great. Thanks, Convener.
Brian Whittle.
Thank you, Convener. Good morning, Karen. A couple of things that have arisen out of the conversations that have gone so far. It was raised with Sandesh and Gulhane. I think you said yourself it was around the issue around trans. And my colleague Joe Fitzpatrick quite rightly has highlighted the vulnerabilities across and how we deliver healthcare across that. But can I ask a question in terms of vulnerable patients? Are we seeking informed consent? Because there is an issue across informed consent that keeps rearing its head. Where are we with informed consent and the issue with that?
Yes, well, I am concerned about that, because it's not something that I've dived into yet, but I am hearing, again, vulnerable patients, you know, having care, not chaperoned, not having informed consent. It's definitely something that I feel is happening. How widespread it is, I don't know. So it's something that I'm going to be looking into. One, you know, again, everybody's reassuring you that they have chaperone policies. Do they have, you know, do they actually, you know, as a GPs do it all the time. If they're going to do any sort of physical exam on a patient, they will bring somebody into the room. Why are we not doing that in hospitals? I think there's a bit of a blasé approach about it, so I really want to make sure across. I'm speaking to the board chairs at the end of the month, and it's something that I'm going to ask them to make sure that, you know, how can they prove to me that informed consent is happening and that chaperone is happening with patients.
I think my concern here is that there's potentially a legal breach here, that we don't need any more of that within the health service. I agree. Yeah, okay. And that would probably lead me on to my next point around whistleblowers. Again, that was raised before, and you know, every board will tell you that they have a whistleblower champion. They have somebody, you know, they can go to. The reality is very different to that. And how do you change that whole culture of trying to shut down whistleblowers? Because it's not peculiar to one area. It's across the whole of Scotland at the moment.
Well, clearly what we're doing isn't working, so we need to be looking at it and saying, you know, I wouldn't go to a whistleblower champion in my trust, because there would be no confidence in that for me, because I'd be concerned about my job. So I think we have to look at how we're dealing with whistleblowing, because I'm literally hearing it once or twice a week about people are afraid to whistleblow, they're afraid of losing their job, they're being bullied, you know, and shut down at any point. So clearly how we're doing it isn't working. So I think we you know, I know even his have a whistleblowing you know, route, but I could not persuade the people that I'm talking to even go down that route. So if people are feeling scared of whistleblowing. What we're doing isn't working, and it's not keeping our patients safe.
I mean, and moving on from that, I mean, you've stipulated that part of your job is to those never again events like the Eljamel.
Yeah.
You know, never again can that happen. But I know that one of the issues was that somebody said they're not convinced that if there was a rope surgeon right now in our health boards, the same actions or some of the actions that should have been taken in the Eljamel case would be taken now. One, there's two things there. One, do you think that's right? And two, if it's not right, how do we change that confidence factor?
Yeah, I'm not confident that it wouldn't happen again at the minute.
Wow.
From what I'm hearing, and it is just that it's that closing ranks and shutting things down. So I'm waiting. Obviously, you know, the inquiry's going on with that, so it's I don't want to dirty the waters, but equally, even within the board that happened, you know, I think there are still concerns. So I do think we have to start trying to open doors that have been closed, and trying to stop boards closing rank and stopping things, because there's nothing safe about that. And also, I couldn't work in a work environment if I was continually shut down.
I'm not quite sure what to say about that. I mean, from you know, I suppose that the question would be, from your perspective and the role that you have, what has to happen to make sure that can never happen again?
Well, that's why I'm saying that I think we have to change or speak up. You know, what we're doing about. You know, if if a nurse or a patient is concerned, and it's just like that shouldn't have happened that way, do we then take that out of the internal, which I think we need, you know, an independent voice, whether that's me. You know, I'm not saying it's me, but I think what we're doing, how we do things now isn't working for staff, and it isn't working for patients, and it's not keeping Scottish hospitals safe. If staff are worried about a trend happening and they don't feel that they can express that, what are we doing? We're in healthcare. We shouldn't be allowing you know, nurses, doctors to feel like that. So I think we have to really, really look at that. So something that I will be putting on my website is, you know, if you are concerned about anything that's going on in your workplace, you know, talk to me. Okay. I guess, you know, that could open my floodgates, and I've only got 4 staff. No, I did. But you know, that's why I'm kind of saying we've got to stop it earlier. We've got to stop it at the first whisper that hang on, this feels like another Eljamel, or, you know, God, hopefully not, but you know what I mean. I'm just saying we've got to try and stop it earlier, and I'm not sure we're doing that yet.
Okay, thank you. The final one I've got is, you mentioned again that you have no real national reporting, and one of my, you know, my hobby horses is around the data analysis, intelligence gathering. I'm not sure we don't have enough evidence, data and whatnot. We just don't look at it properly, don't you know, explore it properly. So where are we with that? Is there a need there to have a real look at how we deliver data and get data gathering?
Yeah, I mean, obviously that takes very smart technology, because, you know, even when I was talking to Stranraer and I had asked them, give me all your datexes, and she said, well, I have to go in to every individual datex and read it to tell you. And I'm just thinking, you know, you know, there's no data that can scan. You know, we're not using any system that can. And so, like, honestly, I said to her, I do not want you going into 100 patient notes just because I've asked you for datex, because, you know, she's a very senior midwife. So why can't we just generate a report from? I mean, they don't use datex anymore. Actually, I can't remember which one it is they use. But I'm just so. In face, yes. So it's just like, and I think it's probably, I don't know if they're very satisfied with it, but I'm just saying, there's nothing there's no emotional intelligence in the data that we're gathering, again, to give us those proactive, preemptive themes to think, oh my gosh, you know, nationally we're getting a lot of these because nothing pulls all that data together. You know, is that what I'm going to do in the first 6 months? Probably not, but is it something that I would like to target? Absolutely. You know, but that's going to come, you know, that's a government decision. It's not a little patient safety commissioner, you know, decision. But I do think if we're going to make Scotland safe and safe for patients, we have got to be looking at intelligently at the data that we're taking, but we're not doing anything with because we can't, you know, merge it together.
I would urge you to keep talking about that. Yeah.
Thanks very much. I wanted to just follow on from my colleague a little bit about the Eljamel situation. I mean, obviously, the overwhelming majority of our surgeons and staff in the NHS are amazing and do a fantastic job. Eljamel, there were two particular aspects. Obviously, there's the inquiry ongoing, but for me, there's the closing of ranks, which you've talked about, and I think we probably all accept that we need to get better at that and make sure that, you know, the duty of candour that is in the law now, and the whistleblowing legislation that's in law now, these are all used to benefit patient safety. The other aspect of that, though, was that obviously Eljamel was performing out with his competences. When you're saying that you aren't confident that the Eljamel situation could happen again, could that happen again where someone who is not qualified ends up doing like surgery that they are not qualified for?
Well, what I don't understand is how that wasn't challenged at the time by some senior, you know, by the senior medical officer, because I don't know what is within the rank of a neurosurgeon. But somebody, you know, needs to know it, and he clearly was going outside his scope probably every day he practiced. Yeah. Am I confident that won't happen again? I don't know, because I don't know who should be, you know, watching somebody like him. You know, we have to look at our centres of excellence and say, well, what are we saying, and almost defining the roles better in saying, okay, well, you're a neurosurgeon, these are the things you should be doing. If you're doing something outside of your sphere of, you know, as a nurse practitioner, you know, I didn't do maternity because it's not my you know, it's not my sphere of excellence. So therefore, you shouldn't be doing something that's not within, you know, as a clinician.
So obviously, I mean, Eljamel started practicing in Scotland in 1995 before this Parliament even existed. And a big chunk of the regulations around employment is still reserved. So just to check that once the Eljamel public inquiry is published, that you would be liaising with your UK counterparts to make sure that those aspects are dealt with, because we need to have confidence that the staff in Scotland and across the UK are competent to do the work that we put so much trust in them. We know that the overwhelming majority are, and it's these tiny number of cases, but
yes. Yeah. Yes, I have to, as I say, I need to wait for the output of that. But then, you know, I meet with the GMC once a month as well. So I'm meeting with the right people, I hope, so that I can flag these things. Because you're right, you know, we do not want that happening again. So therefore, what are we doing about making sure that people are keeping within their, you know, their practice what they should be doing?
Okay, thank you.
Sandesh, Gulhane.
Thank you for bringing me back in, Convener. It's just such an important issue. As a doctor, when I was working in orthopaedics, I've come across a surgeon who was not competent to be performing the operation that he was doing. And this is a problem at consultant level. There isn't really a competency that you can say you can and can't do that, because you're a consultant and you are trained in the specialty that you're in. But one of my big concerns that I think going forwards is in GP. We have physicians associates who are actively saying that they can do everything a GP can, and a lot of undifferentiated patients in GP are being seen by people who are not GPs, and To me, this is a patient safety issue because I don't think there is the necessary qualifications to be dealing with that. I just wanted to know what your thoughts were.
Yes. I, as a nurse practitioner, worked at a GP surgery and did all their house calls for them. So, you know, as a nurse practitioner, and I know you're not talking about those, you're talking about physician associates, but I think there's a big gap between physician associates and a nurse practitioner. You know, in the fact that a nurse to be a nurse practitioner, you've had to been an RN before that, whereas physician associates can just come straight in from being a car mechanic to suddenly looking after people. So I do understand that, and I do feel that they should have they definitely should never be telling people, you know, they can do everything a doctor can do. But I do feel we should be making sure that their competency, that the framework that they're working under, you know, should always be under the guidance of a GP. They shouldn't be working independently of a GP. They should be, you know, especially, you know, when I worked in a GP surgery, if I was concerned about something, I would just knock on a door and say, hey, you know, I'm thinking this, but it might be this. Can you come and have a look? So I think even with physician associates, we need to be careful that the top of their licence, working practice keeps the patient safe. So whatever that is documented. I mean, the problem is that's a UK-wide registration. It's not a Scotland only. But we should definitely. I haven't looked into it. I don't know how many physician associates are working in GP surgeries, but I would be interested to know what they're working under within the that GP group as to how are they guiding the care that person is giving.
Thank you.
Elena Whitham. Oh, sorry, Paul Sweeney.
Thanks, Commissioner, for coming today. Just wanted to ask a quick supplementary just on this prevention aspect. And we know there is a worry amongst many in the NHS that cuts to issues like facilities maintenance, for example, can create a culture of scarcity that is unhelpful for embedding a true focus on health and safety for staff. We had a recent report in the last few days about a broken lift at the Glasgow Royal Infirmary that's been broken for over 6 months, leading to significant lost appointments. There's been reports about sanitation issues in hospital wards, broken showers and so on for long periods of time. Just wondered how that general pattern of poor facilities management could undermine a culture, or at least undermine confidence that the NHS is a prevention-focused organisation, and how do we rebuild that using a combination of inquiry and lessons learned?
Yeah, I mean, I agree. It's not a great picture to look at if you're walking into hospital and the lift's been out of action for 6 months. So for me, no board has a bottomless pit of money, but for me, functional facilities should be quite high on the list, because even that is, if the showers aren't working or a lift's not working, that's still it's a patient care issue. You're not prioritising what's happening with the patient. So I definitely think it's something that we should be looking at, to say that you've got to almost enforce that your building is a safe building, and that it's fully functional and operational. We shouldn't be putting patients into buildings that aren't fit for purpose. So I think we need to be looking at that for sure.
Just assume that the nearby Marriott wouldn't have the same problem. So why does the hospital have that problem? Perhaps there is benchmarking opportunities there.
Yes. Thank you. Yes, that's worth thinking about.
Just also want to look a bit about your role in implementing your sort of recommendations, if you like. So, as a parliamentary office holder, do you see any role for yourself in reviewing the implementation of public inquiries and reviews that are relevant to patient safety and making sure that those recommendations are actually being delivered?
Absolutely. I think that's very, very important because, there's no point in spending public money in an inquiry and then, that inquiry making recommendations and that not followed up. So now, I don't know what his role is in that. So I would need to be working with them. But anything that they need to implement that I feel is to do with patient safety, I would definitely be. I feel like we should give these people timelines. It's just like don't just the soft approach. And the sort of the hand holding that sometimes happens with boards. It's just like, no, this is the recommendations. You've got 6 months, we're coming back in. CQC in the UK, they give you 6 months and say, we're coming back in 6 months. If that's not sorted, we'll downgrade you. And so I think if we really want to focus on patient safety, we have to get our big boots, our big hobnail boots on and kind of call people out and say, you've got to do this in this time. A time frame that's reasonable. If it's something massive that they need to do, then a time frame that's reasonable. But, again, I'll bring it back to accountability. I think that's the biggest safety gap that we have, is the lack of accountability and the lack of people speaking up and saying, I put my hand up, it's our fault and we're going to sort it.
So we kind of covered benchmark opportunities, time-bound accountability for implementation. Just wonder if there's any other metrics or processes that you have kind of envisaged using to assess whether interventions are being properly implemented and are actively promoting patient safety.
It's not something that I've thought of as yet, but again, it's definitely something that we need to do to indicate, because there's no point in implementing change if you're not looking at improvement. If you're not saying, okay, well, a year ago, there were 800 deaths in our A&Es that could have been avoidable. Now there's only, next year there's 200. So we have to be looking at whatever is being implemented is improving patients' safety. So it's something that I will be looking at when our office recommends change, that actually that change happens. And I will be giving them timescales for that.
You mentioned the Care Quality Commission as a sort of template, if you like. Is there anything similar to that you've also been looking at?
Not really. That's why I'm trying to. You have Healthcare Improvement Scotland that does do the investigations and then does do the improvement. And that is a positive on the CQC, because the CQC wades in, tells you off, wraps you around the knuckles, but actually doesn't help you to implement the change. So I think his have that advantage over CQC, but I'm not sure it has the same authority. So it's just trying to balance that. So I do think there are good things that are happening, and we can't let the bad muddy the good. We have to amplify the good and sort out the bad.
Great. Thank you very much.
Elena Whitham.
Thank you, Convener, and good morning, Commissioner. This has already been touched on quite a lot this morning, because I think it really is at the heart of the issue of why we're in the situation we're in, and that's round about cultural change and the cultural change that's required. And this committee stage 1 report, when the bill was proceeding that actually created the office of the Patient Safety Commissioner, actually really highlighted that at the heart of this is systemic failures and not always gaps in policy. It is really about that deep-seated cultural and behavioural patterns that we see within the healthcare system. And you've already touched on some of them this morning. So if we think about not listening to what patients are saying, or if we think about the lack of accountability and the closing of ranks, do you also perhaps feel as if the very structured, hierarchical nature of our health boards have any role to play in why we are seeing, what these cultural barriers are to change?
So being new to Scotland and Scotland health system, when I first came, I thought, oh my gosh, 14 boards is a lot. It's a lot in a small country. So I think we're already setting ourselves up for it being difficult to implement, national change, because you have all of these. Now, I know they're working to share learning and experiences together, but I certainly feel that having so many boards is something that I probably will have no say in, but I do think it makes it quite difficult to implement something on a national level because of that fragmentation. So I do feel that how the boards are set up again is creating that silo and the closing rank. But I'm hoping that I can build trust with them, and that we can try and change culture to not about blame, but about shared learning and actually all in it for the patients. And the minute it doesn't really feel like that, boards are under immense pressure. They have very tight budgets. Wards are imploding. So I do understand the operational stretches and strains on the system. But that's no reason why we shouldn't be creating forums and environments where boards don't feel they have to close ranks and shut things down, but they do feel that actually they should feel, you can't, empowered isn't right, because you don't empower people, they empower themselves. But we need to make sure that we have a system that is helping people to implement change and be open and honest and have integrity and accountability all the way along, from the smallest decision they make to the biggest decision, shutting a unit or shutting a ward. I think there has to be openness, honesty and integrity, which there doesn't always feel that there is.
And if we think about individual healthcare settings themselves, they still have that very structured hierarchical system in place.
I agree.
How do you foresee shifting the culture so that anybody within that setting actually feels as if they are empowered to be able to call out things that they see them and that they do have protection? Because I think at the heart of the issue is, employees, workers not feeling as if they can speak out, or indeed patients, if they're speaking out, perhaps they're not being listened to. So driving that cultural shift that needs to happen, how do you foresee that?
Yeah, I think something as mammoth as that has to be done, one step at a time and one day at a time, if you like. Looking at when I get involved with something within a hospital, I will be bringing in that the voice that says this is safe. You need to learn to be able to speak up. So I want to be able to implement that change through the lived experience of both staff and patients. So when I'm sitting down talking to nurses who are so stressed because they don't feel that they're being heard, or they're concerned about something, that actually we then try and knock that on the head there and then and say, well, right, let's go talk to your managers now and let's see why that culture is inherent here. Because, to break down national systemic culture of hiding things and not being able to speak up, you're not going to just do that with the wave of a magic wand. You have to do it living the experience with those people and trying to move that forward with them and helping them. And that's what I hope this office is going to be able to do, that every instance that we're involved in, we will make sure that everybody feels safe to speak out, and that cultural change starts to move forward.
And I guess, how are you going to be able to measure and monitor that cultural change? Because we already know, as you've spoke about this morning, that the lack of data is a big difficulty. So how is your office going to actually monitor that and evaluate it?
what I would hope is that that lived experience of people fearing for their job and their you know, and they're not speaking out. I would like, you know, the volume of speaking out to increase. For me, that would then mean that there's a change in culture. If we're actually, if you know, clinicians feel and patients feel that actually, do you know what, this is now the time that our voice is going to be heard and it is going to change. So that's the only way you're going to measure it. If nothing changes, you know, 2-3 years down the line, if people are still feeling not heard and staff are still feeling that they can't speak out because of the threat of losing their job, then you know, the system is not working. So I would hope we would be able to move that forward.
And finally, for myself, how are you going to ensure that there's lasting organisational change that comes about, and it's not just pockets of localised improvements? And who are you going to work with? What other organisations? Because obviously we need to think outside the silos. How are you going to drive that lasting change?
Well, I would, for me, it's around what training is lacking. What you know, what leadership training is lacking? Do we need more education around it? Because you can't, as you say, you can't just say staff have to be heard. People have to know how to respond to that. So I think there needs to be some process change. There needs to be more education, and there needs to be a change in jobs descriptions and things like that to say, actually, do you know what? You know, part of my role is that actually I have to hear the lived experience of patients and do something about it, or I have to hear the lived experience of my staff and do something about it. So I do think it's more than just listening. It's actually looking systemically at what can change, what other education needs to happen. Do we need to change leadership structures? Do we need to change, you know, how patient complaints are dealt with within hospitals? So I think we have to look at the whole system and think what we're doing now isn't necessarily working. So, and change isn't good for change's sake. Change has to happen for a good output and a result in better patient care and better safety for patients.
Thank you.
So I'm going to ask a sort of final question,
Sure.
But I'll put on record that I hold a bank nurse contract with NHS Greater Glasgow and Clyde. You've spoken quite a bit about maternity services this morning, and certainly in Parliament we've heard some criticism about the delivery of neonatal services and the Best Start report that recommended moving to 3 sites for neonatal intensive care. For patient safety reasons, and we've heard clear evidence from clinicians about why they feel that's necessary, and the charity bliss for the safest option for the most premature and sickest babies. I know you've spoken about this before, and I was wondering if you could set out to the committee your thoughts on that redesign of neonatal intensive care.
Sure. Again, neonates aren't my forte, but I do understand the need for centralisation and the local expert for those fragile, you know, perinatal children. So I do understand the decision made, but again, a little bit like maternity, you can't just make decisions like that and then not back it up with implementing other things in the local area. So for me, that is always the gap of change. It's just like, this is a great idea, we're going to do this, and then leave the devastation behind. So I think even with that, there hasn't really been a total in the redesign and the expectation that families will travel. We still have to look at the risk mitigation and what are we doing in the local areas so that those families feel supported to then have to travel to the centre of excellence. So I would want to be looking at, hopefully within the task group again, listening to the voices of the families to say, how does this feel for you to do this? And where is the service gap between, you know, suddenly your local neonate is taken away and you have to travel, you know, where is the support locally with all of that? So I think that is the issue with service redesign, is that the focus is on the end product and not on you know, the kind of tsunami that it's leaving behind. So I would like to kind of be looking into that.
So there needs to be robust communication.
Yes.
Honest communication, and probably less politicisation of some of those service redesigns, so that families actually get correct information about what's changing and how that may or may not affect them, to alleviate some of that concern and worry. Is that?
Yes, I agree with that, and I think that is one of the big gaps. Is that you know a little bit back to Stranraer. Stranraer don't know what Dumfries and Galloway have done in order to mitigate the risk. Now they may have done some stuff, and so it's the same with this. The families, you know, you should almost like hold a town hall in the local area to say, this is what we're doing. You know, that's what I want to do with my role, is just go out into communities and hear what is concerning them, and then trying to match the decision that's been made within the health authority with the information that's being given to the local community that they're serving. And I think that's the gap that seems to be happening with all these things. There's just either misinformation or lack of information. And I think it's very important, actually, for the safety of everybody involved, that everybody gets the right information with service redesign, and not just, you know, this is happening and that's it kind of thing.
Can I thank you for your attendance this morning? And I'm going to suspend the meeting until I for a changeover of witness.